Testing 1 2 3. 1 2 3. Test 1 2 3. Testing 1 2 3.
or as we call you in the eye world, real doctors and providers. So it's great to be here. So financial disclosures, none relevant. Student loans, however, that's a different story. In terms of an outline, I'd like to give just a brief overview of the eye and some common eye conditions that you might see in your day-to-day clinics and in settings. We'll talk about a basic eye examination, one that pretty much anyone can do without any fancy equipment. And then we'll talk about these ocular emergencies, things that you would not want to miss if they showed up in your clinic, in your hospital bed, in your ER. And we'll talk about initial management and how to treat these. So my hope is that this will be relevant for you all clinically, and you'll maybe learn a few things. So vision is important, obviously. Thank you, Captain Obvious. So vision is a privilege for me to take care of patients, to help them see better, to protect their vision, to preserve their vision. And patients consistently rank vision amongst their top health priorities. So if you do a survey of patients, this was done just a few years ago, they actually ranked losing vision as the worst possible health outcome for themselves, above things like Alzheimer's disease, cancer, HIV, AIDS. So people are very afraid of losing their vision. Understandably so, because it affects your day-to-day life in such an extreme fashion. There aren't really very many meaningful activities that we do where we don't rely upon vision, sharp vision, good vision to carry out our tasks. So they rank losing their eyesight as the greatest effect over things like memory, limbs, speech, and hearing. In this country, so a developed country, we have about 3 million currently patients or people that are visually impaired. Visual impairment's defined as kind of the 20/40 to 20/60 level on the reading chart, so right about driving level vision. And then in those 3 million, we actually have 1 million that are legally blind. Legally blind means that you can't see 2200 or worse, and that's in your better seeing eye. So your eyes are at that level or worse. Because of our kind of aging demographics in this country, eye disease, like many other diseases, are projected to significantly increase. And these numbers here are supposed to double by the time we hit 2050. So the American Academy of Ophthalmology does have some eye screening recommendations. What are those? So children really should be screened at birth. Typically the pediatrician will be doing this at the time of birth and maybe at the first post-birth visit. Again, at 1 year, you should have an eye exam just to rule out any occult pathology. Kids aren't obviously going to be able to tell you there's much going on. And then at preschool age and school age, it's good to have just a general eye exam to make sure there's nothing bad there. Adults, the Academy recommends an exam once in your 20s and twice at some point in your 30s. This is, of course, for people that are completely asymptomatic. They feel like their vision is fine. They're not having any trouble. They're not needing glasses. And then a baseline exam sometime around 40 years old. 40 years old is really when you want to have your vision monitored more carefully. That's when some of these conditions we'll talk about first can get started. So after your baseline exam at 40, typically the eye doctor seeing you will have a recommendation whether it's every year, every 2 years, and beyond. Once you hit 65, that's really when a lot of the more high-risk diseases that we see in a country that's developed, like the United States, that's when we start to pick up on those. And from that point on, it's really every 1 to 2 years that you should be having an eye exam. So what are these common eye conditions? The big three are really diabetes, glaucoma, and macular degeneration. Diabetes is really the #1 cause of vision loss and blindness in adults under the age of 55. Obviously, with the way the numbers are trending, diabetic exams, diabetes in general, the incidence is increasing, so it's important that we screen patients for these types of findings. About 1/3 of patients with diabetes will have some findings in the eye, some diabetic retinopathy. Diabetes is a micro and macrovascular disease, and the eye is really the only place we can see in vivo blood vessels. And the same changes that are happening in the eye are the changes that are happening in the kidneys, with the microvasculature in the heart. And so if you see eye disease, it's probably happening elsewhere. And sometimes, the eye is the first place where we think about diabetes and actually diagnose diabetes. So this picture is an example of diabetic retinopathy. There's some hemorrhages in the retina, the back of the eye. There's some exudates. Remarkably, this patient might be totally asymptomatic. They might actually see fairly well and not have any significant trouble. This is really a time for when you can catch disease, because if you catch it at this stage, you treat the sugars, you do little treatments in the eye if necessary, you can prevent it from going down this path. This is the type of thing that causes vision loss and blindness. When you get permanent damage to these very sensitive ocular tissues, it can progress to this type of picture where there's a detachment of the retina, there's fibrosis, there's tugging, there's ischemia, there's profound hemorrhage, and really once it reaches this stage, it's very tough to go back. So the idea in screening for diabetes in our patients on a once-a-year basis is to prevent it getting to this area, to this late in the game. So the screening recommendations for diabetics, really at the time of diagnosis, we don't really know how long patients have been diabetic for, so that's a good time to get them in. And then annual exams thereafter. And in the eye clinic, when we see these types of things, we'll kind of stratify how often we want to evaluate patients, send them for treatment if necessary to just prevent vision loss down the line. Again, in younger patients, this is the leading cause of blindness in this country. Macular degeneration, so another big one. This is the most common cause of blindness above 55 years old in developed countries. So on the left-hand side, you see a picture of the retina, and you see these little spots. This is what's called drusen, little deposits in the retina. In macular degeneration, our eye, which is constantly clearing out these waste products, the retina stops doing that as well, and you get deposits of these waste products, and over time, that causes deterioration of the tissues, ischemia of the tissues, and in the right-hand side, you see this atrophy, this atrophic appearance of the macula and the retina. The macula is really the central part of your vision, so if you develop atrophy here, you're really not able to see anything down the middle, right? When you're looking, wherever you're looking right down the middle, you lose your vision there. This is dry macular degeneration. There's also a form of macular degeneration called wet macular degeneration, where as the eye becomes atrophic, it tries to grow in new blood vessels. These new blood vessels are very prone to bleeding and leaking, and when it bleeds like this in the retina, it can become very inflammatory, and you end up with significant vision loss that can happen very quickly. So screening for macular degeneration, there are treatments for it. There are vitamins that you can take as well, something that most adults over the age of 65 should have an eye exam for once a year. This is an example of what a patient with macular degeneration might notice. Normal vision on the left side, and then macular degeneration having taken away that central vision there in the picture on the right side. Finally, glaucoma. Glaucoma is the leading cause of blindness in African Americans in this country. We see quite a bit of it here in the South. Where I did my residency training up in Milwaukee, Wisconsin, we didn't quite see as much, and it wasn't as aggressive, but certainly down here, Birmingham, the South, we see a lot of glaucoma. Glaucoma is dangerous because it doesn't hurt, and it typically happens very slowly. It starts by taking away your peripheral vision, and so most patients are able to adapt, and then unless it starts to become real severe, they might not even know they have it. About half of people with glaucoma in this country don't even realize they have it yet. So the very characteristic cupping you see in glaucoma, this is a healthy optic nerve here on the left side, and on the right you can see there's just been a loss of tissue here in the middle. That's called cupping, very characteristic for glaucoma. Glaucoma causes loss of peripheral vision, so in contrast to macular degeneration, your central vision may be very good, and that's why it's oftentimes asymptomatic. So for all of these diseases I just mentioned, early diagnosis really is crucial in treating and stabilizing them before they get to the point of no return. If you're catching it late in the game, you're already working behind the 8-ball, and there's not very much we can do oftentimes to restore much of that vision. Finally, we'll talk a little bit about cataracts. Cataracts are not a disease. Cataracts involve the clouding of the natural lens inside of the eye. So we're all born with a lens that does the focusing for us. When we're younger, it's nice and clear. It can zoom in and zoom out. At some point in our 40s and 50s, it loses that flexibility, and everybody needs bifocals or reading glasses. That's a change in the lens. We have not been able to overcome that limitation just yet, although people are working on it, that focusing limitation. So over time, the lens starts to become cloudy, like it is on the left-hand side of the picture, but the patient's right eye. We call that clouding of the lens a cataract. Cataract surgery is the most common procedure performed in this country. It involves kind of removing the cloudy lens inside of the eye and replacing it with an acrylic plastic lens that stays with the patient forever. The cataract never comes back. It's a very safe and effective procedure. If and when you need it, we get our patients seeing much better, and they're very grateful. Finally, conjunctivitis. So this is something that I'm sure many providers here will encounter from time to time. In adults, most of the conjunctivitis strains are adenovirus, so it's a viral infection. This is also commonly known as pink eye. It's often bilateral, so the classic story is that it will start in one eye, it'll spread to the other eye within a few days, and then both eyes, when they come in, are affected. You'll oftentimes see some lymphadenopathy, preauricular, that kind of confirms that it's a viral infection. When these come into our clinic, we treat conservatively, just like you would for a viral URI. Antibiotics really don't have much of a role at all in treating viral conjunctivitis. So cold compresses, moisturizing drops, hand hygiene is very important. You really want to avoid the spread of conjunctivitis. It can be very contagious. So after the patients leave our clinic, we really take Clorox wipes and we wipe every possible thing down, from the chair to the microscope to the door handles, and sometimes even in the waiting areas, because this can spread very quickly. So hand hygiene, and then in appropriate patients kind of staying off work. Usually lasts about 7 to 10 days, and it can be pretty miserable. We want to avoid antibiotics, like I said, and also steroid eye drops if you're not really sure what you're dealing with. Steroid eye drops can make certain conditions worse, certain conditions that mimic conjunctivitis. So if you really are concerned about the conjunctivitis, the severity, the issue with the eye, it's probably most appropriate to refer the patient to an eye doctor for an evaluation and consideration of treatment with these prescription medications. Bacterial conjunctivitis, it's much more common in children. So actually, if you have a child with conjunctivitis, it's much more likely to be bacterial. The hallmarks of bacterial conjunctivitis are going to be more mucopurulent discharge. There should be quite a bit of that. And for these patients, it is appropriate to put them on antibiotics. So if there is a big mucus discharge type of component to the conjunctivitis, then an antibiotic may be appropriate. Typically, we do polytrim. Erythromycin ointment's a great option as well, or a fluoroquinolone such as ofloxacin. We really shy away from gentamicin in most of our patients. I've seen a lot of patients come in on gentamicin from other providers. Gentamicin can cause a lot of problems in the eye. It's oftentimes not tolerated very well. So if you can, I just recommend trying something else. All right, so for your patients that don't have insurance, maybe they can't get a good eye exam, they can't get screened, there is a program offered through the American Academy of Ophthalmology called Eye Care America, where if you don't have insurance, you don't have the resources for eye exams, you can go through this. It's on the website, and there are eye exams that can be administered from this program to help our patients. So if you run into that situation, just refer them to the website Eye Care America. All right, just a little bit about an optometrist versus an ophthalmologist. So an optometrist is an eye doctor that's had 4 years of college and then 4 years of optometry school. They're very good at basic screening eye exams, doing general eye exams, prescribing glasses and contacts, certainly very appropriate. In this state and other states, they can administer medications to treat eye disease and monitor. They do not do any procedures or surgeries. So an ophthalmologist, on the other hand, we've got 4 years of medical school, 4 years of residency, and then an optional fellowship of an additional 1 to 2 years. We primarily diagnose and treat eye disease and eye pathology, and we perform surgeries and procedures as well. For the most part, if you have a significant or severe eye problem, it's probably best that you see an ophthalmologist. There are certainly many optometrists that are capable and able to manage many of the more minor diseases. And there are more optometrists in this country. They're about 2 to 1. They outnumber us. And actually, my wife and my sister are both optometrists, so even in my family, that's the case. And in a perfect world, we kind of work collaboratively and treat our patients, and oftentimes we're able to do that. So that's just a basic, kind of quick difference between the two. All right, so a basic eye exam, what can you do if you have a patient in your setting? They're maybe having an eye problem. What can you do to just evaluate this and work this up, see if it's really anything to worry about? So kind of the 4 main things that you'd want to evaluate and look for. First is the vision. You don't need all this fancy equipment that we have in the eye clinic to really do this. So the basic eye exam, most people will have an eye chart in their clinic, and if you don't, if you're in the inpatient setting, you can pull up an app on your phone that will do just the same thing. This one's called Eye Handbook. I have it on my phone. It has a kind of automated eye chart there. So basically, you want to see what the patient can read. And you want to do it one eye at a time. Because if there's a problem in one eye, you won't pick up on it. If the other eye is totally normal, they're going to be able to read all the way to the bottom. So one eye at a time. If they need reading glasses, if this is a patient that has bifocal or reading glasses, because this is a reading exam up close, you will want to have them wear their glasses for that. And so you should be able to very quickly at least see the level of vision. If they can't see any letters on the chart, then doing something like counting your fingers is helpful, or just seeing which direction your hand is moving. Those are kind of the next steps up. So obviously, if they can only count fingers, they can't see any letters, or they just can tell that your hand is moving around, that's fairly profound vision loss, and that you'd want to be concerned if that was a new discovery or a new complaint. So the convention for vision, what does 20/20 versus 2200 vision, what does that actually mean? So 20/20 vision is kind of our benchmark for good, standard, quality vision. That's considered normal vision, and that means that at 20 feet, you can see the letter down to the very bottom. That's the letter that we would expect a normal person to be able to see. So 20/20, at 20 feet, you can see the same thing as a normal person. 2200 vision means that at 200 feet, so at 200 feet, a normal person can see this very big letter on the top. But someone with 2200 vision actually has to be all the way up to the 20-foot area. They have to be much, much closer, 180 feet closer, to be able to see that big letter. So the higher the number that second number is, the further away the normal vision patient would have to be, and the worse the vision is. So the higher that number, the worse the vision. So that's what that convention is. All right, so the next thing you might want to look at is what do the pupils look like? So we know, the pupils, that black circle inside of the eye. The iris is the colored part of the eye that kind of moves in and out and reacts to light. We test the pupils with light. So you want to shine a light across the eye and see how that pupil reacts. Does it come in? Does it come in briskly? Does it not move at all? You probably want to dim the lights a little bit just to minimize any reaction from room lights. But you can see that on the top here, this is an eye that doesn't have the light in it, and when you shine the light, they constrict. So that's a normal reaction to the light, a constriction. On the bottom, you have a dilated pupil there. Meiotic pupils, very tiny pupils, 1 to 2 millimeters. You can see these in certain medications. So opioids is a big one. If you have someone that is maybe taking chronic pain medication, or they're in the ICU and they're getting a fentanyl drip, their pupils are probably going to be small and they may not react very well. That's going to be a normal thing. You get meiotic pupils from the parasympathetic system. So either the parasympathetics are overreacting, or for some reason you're losing the sympathetic innervation to the iris and your pupil's not dilating. So it's usually one or the other. Dilated pupils sometimes is more of a concerning finding. You can certainly see it in trauma to the eye or to the brain. Brain herniation, you oftentimes will get a dilated pupil in that context. If it's just one side, sometimes something like a scopolamine patch or dilation drops, if they've gotten something into the eye, atropine, that can dilate the eye. So you might want to ask about any exposures to chemicals at work. And then the sympathetic drugs like cocaine, ecstasy, those will dilate your pupils as well. All right, so moving on. So pressure is the next one. This is a picture of a tono pen. Many emergency departments have tono pens. Using the tono pen involves placing a numbing drop on the eye. Please do that. Your patients won't like you very much if you don't. And then you use this tono pen. It's a device that actually gently taps on the surface of the eye to measure how hard it is. A normal pressure is between about 10 and 21. And it's really not within the realm of your fingertip palpation to figure out whether the pressure is 12 or 15 or 18. But you can you should be able to palpate a wide range of eye pressures. So a very simple way to check the eye pressure is have the patient close their eye and just with your thumb, just palpate across the eyelid. It should feel, and you can do this to yourself, the eye should feel like the consistency of about a grape. It shouldn't be much softer than that, shouldn't be much harder than that. So a grape is really kind of the baseline you're going for. If you're palpating across the eyelid and you're not feeling any give there, it feels hard as a rock, that's probably a sign that the pressure is really quite high in the eye. And in a patient that's got eye pain and redness and the eye feels hard as a rock, the other eye feels normal. That's a very concerning finding for something like angle closure glaucoma, which we'll talk about in just a little bit. Okay, finally the external exam. So what does the eye actually look like? Here's an example of several different diagnoses, and we'll come back to this slide in a bit, and hopefully you'll be able to describe this in a little bit more detail. So this is just a normal eye. We have our eyebrow up top, we have the upper eyelid, we have the lower eyelid. The eyelashes kind of come out at the edges of the eyelid here. When we do our exam in the clinic, we kind of start from the outside and we work in. So externally, we have the brow, the lids, and then the white part of the eye, the conjunctiva and the sclera. It's usually white and quiet. You might see some redness there. You might see some blood vessels. And then moving further back from there, what might you be expected to see or be able to appreciate? The clear part of the eye is called the cornea. It's really the front windshield of the eye. If you were wearing a contact lens, it would sit right on top of the cornea here. So the cornea is what you look at when you look, right at someone's colored part of the eye. Behind the cornea is the anterior chamber. It's a fluid-filled space filled with aqueous humor. And then behind that sits the lens, so the lens inside everybody's eye that we talked about a little bit earlier. Really don't expect you to see very much in the back of the eye. You can with an indirect ophthalmoscope. Oftentimes, if you're good, kind of find blood vessels or find the nerve. But it's really a tough exam, even for trained eye doctors, to really make very much of the direct ophthalmoscope. So going back to these various pictures here, so you'd notice that the eyelids look fairly normal in this eye, but the conjunctiva and the sclera are very red. We call that injection. The pupil here is dilated, but you don't see too much going on with the cornea. So this primarily is a problem probably on the surface of the eye, the white part of the eye. Moving over to the right side, you can see that the white parts of the eye out here on the sides of the picture are red and irritated and injected. But then on the cornea, you see this white opacification. This looks like an infection. This is what a corneal ulcer would look like. Looking deeper from the cornea, you see a little bit of layering here. This is probably some inflammation in white blood cells. This is called a hypopyon. So the inside of the eye is demonstrating some pathology as well. It's kind of settled into that clear chamber of fluid that we talked about. Moving down to the bottom left corner here, you see some blood actually pooled inside of the eye. This is called a hyphema. Oftentimes, a blunt injury to the eye can cause bleeding inside of the eye and result in something like this. A hyphema can cause high eye pressure, certainly blurry vision, and you do need treatment for a hyphema in order to clear it up and make sure that the patient doesn't run into trouble. Then finally, on the bottom right, this is a patient that has a swollen left-sided face. So the eyelids are swollen, the cheek is swollen, there's edema. The eyelids are swollen shut in this case, so externally you can tell a lot. This is probably consistent with a cellulitis. It could be preseptal, or if it's traveling back into the eye, something like postseptal cellulitis. So just looking at the eye and kind of being systematic about it, you should be able to describe what you're seeing. All right, so we'll talk about some of these ocular emergencies now. The first one is going to be acute angle closure glaucoma. So what is this? The patient with acute angle closure glaucoma will probably come to you with just sudden onset eye pain. Their vision will be decreased. When they're looking at lights, they might describe something like a halo around the light. On the eye exam, you'll notice that the white parts of the eye are typically red. If you try and get the pupil to move, it's oftentimes unreactive. And then when you're feeling that eye through the eyelid, it should feel very hard to palpation. You can always compare one side of the eye to the asymptomatic eye if you're not sure what you're feeling is normal or if it's different or unusual. The cornea oftentimes will be cloudy because the pressure is so high in the eye, the cornea actually starts to swell. So what's happening in angle closure glaucoma? Your eye is constantly making fluid to fill up this chamber. It's made here in the ciliary body, which is right next to the lens. The fluid travels over the lens and up into the anterior chamber, and it leaves here in a drain on the right-hand side of this picture. This drain reaches 360 degrees around the front of the eye. It's called the trabecular meshwork. So in a normal eye, there's an equilibrium, a balance between the fluid being produced and the fluid that leaves the eye. In angle closure glaucoma, the iris actually comes up and occludes this drain, and so there's no fluid leaving the eye. The eye continues to produce fluid, and it just has nowhere to go, so the pressure comes up from there, and it can very quickly reach a high level. There are certain medications that can cause angle closure glaucoma, Topamax being one. Some of the sinus medications, if your eye anatomy puts you at risk for angle closure glaucoma, some of the sinus medications can put you into it. Dilating drops can also put you into angle closure glaucoma. What is the fix for angle closure glaucoma? So you see here, this was the picture from before, a cloudy cornea. The iris is basically plastered up, that drain is blocked off. If this patient was in your clinic or in your emergency room, you'd want to try and get that pressure down as quickly as possible. A carbonic anhydrase inhibitor, acetazolamide, if they don't have any contraindications such as sickle cell or sulfa allergy, acetazolamide is a oftentimes safe medication. You want to give them a one-time dose of about 500 milligrams, either IV or orally. And then if you happen to have any ocular hypotensive medications, it's not a bad idea to just kind of blast the eye with about 3 rounds of any of these drops that you might have to try and bring the pressure down. From there, you certainly would want to get this patient to an ophthalmologist as soon as possible for further treatment. When the pressure gets up to 40 or 50 or 60, it can be just a matter of hours before you get permanent damage to the nerve in the eye, permanent vision loss. So really time is critical. So what do we do when we see this patient? Oftentimes we'll do what's called a laser iridotomy. We'll use a laser at the microscope to actually laser the iris here on the side, past the cornea into the iris, and what that does is it allows a channel, so fluid can actually then make its way from the back part of behind the iris to the front and get its way into the drain. Oftentimes we'll see kind of this immediate gush of fluid that's built up behind the iris. It'll come forward and then it'll push the iris back into place. So this is what that type of laser hole would look like. This is not symptomatic, visually symptomatic for the patient. You just see it in the microscope, but this allows fluid from the back behind the iris to flow anteriorly, and that's oftentimes the short-term fix for angle closure glaucoma. Many of these patients end up requiring cataract surgery later on because the cataract is actually what's pushed the iris forward and closed off the drain. All right, so moving on to a globe injury or a ruptured globe. For you golf fans out there, this last fall at the Ryder Cup, there was actually an unfortunate fan. Brooks Koepka hit a drive off the tee, and it went off the fairway and into the crowd. And it happened to just hit this poor lady right on the eye, and it actually ruptured her eyeball. So there was enough force that actually the wall of the eye split open. And the last I heard, she ended up having surgery, and she was actually looking into some litigation in terms of the tour. But globe injury, certainly an ocular emergency. The 3 kind of main mechanisms: a penetrating type of injury, a perforating type of injury, and then just, in this case, blunt trauma to the eye. So oftentimes, the patient, there will be this history of some type of injury coming up to the face, towards the eye. Important to ask about that. Usually they'll have immediate pain or discomfort, and oftentimes profound or significant loss of vision. So it shouldn't really be very subtle. The history will be clear. These are some of the globe injuries that I have seen over the years, the various mechanisms. It's oftentimes a very random event, just a freak accident or occurrence. There was a young gentleman that was fishing with his friend and ended up getting a fish hook to the front of the eye. The lock here, there was a guy working at the gym. He was using bolt cutters to cut open a lock, just an abandoned lock in the locker room, and a piece of the metal from the lock just came up right in his eye. Oftentimes these things, if you tried to do it, replicate it again, you couldn't. They're just freak accidents and injuries. The goat and the cat, those were both within a week of each other just last year. So animals can sometimes cause these types of things. If you notice up close here, there's a young child demonstrating how not to protect your eyes while paintballing. Please don't do that if you can help it. Please don't let your 6-year-old go paintballing if you can. That might be helpful as well. So what would you see on an eye exam when someone's had a globe injury? Oftentimes, one of the main signs that should draw your suspicion is this redness, what we call chemosis or swelling of the conjunctival tissues. There's bloody chemosis. Usually it will go 360 degrees. If you can appreciate in this picture here, the cornea looks a little bit cloudy, and behind the cornea, the pupil is irregular. So typically the pupil will be irregular because there's a defect in the wall of the eye. The tissues are actually being drawn to that defect, and the iris, which is usually a nice circle, will kind of be pulled in one direction or the other. We'll look at that That's also demonstrated in this picture here. So there's probably some sort of laceration in the sclera, the wall of the eye here, and then the tissues inside of the eye are actually being pulled to that laceration, and so the pupil is actually pointing to the area of trouble. Now you might look at some of these pictures and think that this looks a lot like something you might see more commonly in the clinic, just some redness around the eye. This is called a subconjunctival hemorrhage. There's all these little blood vessels on the surface of the eye, and from time to time they can bleed or leak some blood onto the surface of the eye. It can be something like rubbing the eye or straining. These very fine blood vessels can bleed. And someone that takes blood thinners, oftentimes it can kind of go all the way around the eye. Now, how can you tell the difference between one and the other? So first, the history is going to be much different. There's not going to be a big time history of high velocity projectile coming up to the eye. They weren't punched in the eye. They weren't hit in the eye. They probably maybe just woke up with it. They might not even know they have it. The pupil in this case is perfectly round. They usually don't have any trouble with their vision. Most of these patients are asymptomatic. There might be just a little bit of irritation as that blood on the surface can sometimes cause the surface of the eye to dry out. But these patients really should be doing fine, and if that's the case, you really don't need to be worried about something like a globe injury. Sometimes that blood can actually look quite profound. This is a patient on Plavix, and you can see the thinner blood has just made them more prone to bleeding all the way around, and that looks very scary. And it can be for the patient, but the pupil is normal. There's no history of an injury. If you're concerned, definitely have them see an eye doctor within a day or two, but this is not an uncommon presentation of a subconjunctival hemorrhage as well. All right, so this is a patient who had a perforation of the cornea, and you can see the iris is just pointing to the defect here, and some iris tissues are extruding from the surface of the eye, the cornea. This is definitely an eye that's been perforated, and that needs to be fixed before an infection develops. You get permanent loss of vision. And again, one more example of a peeking of the pupil over to the side where there was an injury in the wall of the eye. This is a CT scan of someone that's had a ruptured globe. So oftentimes the eye will look deflated. It's not nice and round. There's not very good contour to it. And that should make you suspicious with the right history. This is an example of a foreign body that's actually made its way into the eye. This would be a perforating trauma. Sometimes if metal is flying up, explosions, people working around grinding metal, that type of thing, it can get into the eye, and that oftentimes, if it's not an inert object, will need to be removed with surgery. Okay, so what kind of management would you do? It's important that you protect, when you see this, you want to protect the eye. So really the first thing you want to do is shield the eye in any way that you can. Many clinics, many ERs will have these metal eye shields, and you just want to tape across the metal eye shield so that no further pressure is placed on the eye. Pressure can extrude contents, and you really want to avoid that. You want to make the patient NPO. Please don't have them eat or drink, because there's a high probability that they're going to be needing surgery, and the longer it's been since they had their last food or drink, the more expedited the recovery and the surgery can proceed. If they're feeling nauseous, it's a good idea to give them some antiemetics. Nausea, straining, Valsalva, those are all things that can increase the pressure in the eye and, again, extrude eye contents. So just ask if they're nauseous. If they're not, that's okay. But if they are, please give them some Zofran, something of that nature. If you're comfortable and you have these available, some IV antibiotics are really a first-line, frontline type of treatment. The fluoroquinolones, particularly moxifloxacin, find their way into the system and can get into the back of the eye, the vitreous, and help protect the eye from developing an infection. An infection of the eye is a really big deal and can definitely cause blindness very quickly if it develops. And then finally, a tetanus, an update on the tetanus if they haven't had one. We typically recommend that. Then you want to refer them for immediate surgical care. In Birmingham, well, this is a picture of just a cup. If you don't have an eye shield, something like a solo cup or a plastic cup, you can be placed over the eye and taped over it as well. So if you don't have a shield, there are some options. You definitely do want to protect the eye. In Birmingham, we're lucky. We have one of the few, actually 24-hour eye hospitals in the country. There's only 3 of them, and one of them is in Birmingham. We're one of the only 3 level 1 ocular trauma centers. So if someone does present with a ruptured globe, you can feel confident that there is a team kind of on standby and at the ready with inpatient beds at the Callahan Eye Hospital downtown. We also have every type of specialist there. So do take advantage of that if you're concerned. All right, so moving on, a chemical injury. So this is, pretty straightforward. Any exposure to a chemical irritant. Tide Pods have been really big lately over the last several years. Kids opening the Tide Pods and just spilling this onto their eyes. But really any type of chemical exposure needs to be addressed. On the bottom here, I had a patient come in once. She was taking a dilating drop for a uveitis or an iritis. And when she went to use her usual dose, she actually reached for this crazy glue, which looks somewhat similar. She had blurry vision from her iritis. She couldn't tell. So she ended up getting this a decent amount in both eyes. So that was not very much fun. I wish they would change the cap on that, but that happens from time to time. So in terms of chemical injuries, basics are actually worse than acids. Acids will tend to denature proteins, and once the proteins are denatured, it actually forms a little bit of a barrier from further damage. Basic solutions, actually, when they get on the eye, will kind of infiltrate the tissues and cause coagulation and a release of a lot of enzymes that actually further destroy or damage the tissue. So basics in this case are actually worse than acids. Now we do recommend you not, if you get an acid on the eye, don't start pouring milk on the eye. Don't kind of try to counteract things. Don't overthink it. What we typically recommend in treatment is usually immediate. Try to irrigate the eye when you see these patients. Saline or lactate ringers are really good solutions. If you don't have those available to you, then just standard tap water is fine. It's really important just to get that out of the eye as quickly as you can. So there are some instruments that some emergency departments have, and we certainly have in the eye clinic. This is called a Morgan lens. Basically, it's just simple tubing. You hook the other end of this up to saline or a bag of LR. You place this over the eye. You might want to give the patient a couple of numbing drops, and then you hang the bag of fluid, and it just slowly kind of trickles and irrigates the fluid. Oftentimes, it takes several bags before you kind of get everything out. So what do chemical injuries cause? They can cause lots of different things. They can cause abrasions of the cornea, so sloughing of the surface. If it's severe enough, it can cause some stem cell deficiencies around the surface of the eye. So at the edge of the cornea, we have what's called limbal stem cells, and those stem cells kind of keep the surface of our eyes happy. And if those get damaged, then the surface of our eyes can very quickly degenerate and permanently scar down. So the longer these acids or bases are in there, the more time it has to cause damage, and the quicker you can run into that trouble. So after you've irrigated, what you want to do is, if you have a pH strip, wait about 5 minutes after irrigation, because the solution can kind of fudge things. But place a strip, just lower the eyelid, make a little pocket there, place the strip in there, and then see what ends up coming back. You want a neutral pH somewhere around 7 to 7.4. If it's higher than that or lower than that, you want to continue irrigating until you can get that down. You really shouldn't refer the patient to an ophthalmologist if the pH is still out of control, because you're going to be losing time. That chemical is still in there. It's going to be causing issues. Really clear that out before you refer to an ophthalmologist. Certainly at Callahan, we see a lot of this, but a general ophthalmologist or in your area would be fine as well. On the bottom here, you have a picture of an eye. So this is a chemical injury. You can see some whitening here. So whitening is actually bad. That means that the limbal stem cells over here have already started to die off. And so if you see a chemical injury and the eye is white instead of red, be really concerned for that. This can progress to something like this: permanent scarring, permanent clouding of the cornea, and these patients don't really have any vision, and there's unfortunately not much that we can do for them. But if you catch it early, they're treated appropriately. There's things like drops and sometimes steroids or even amniotic membranes that can be placed on the eye to try and reverse course and get people seeing again. All right, so moving on to the next one. This is a patient here. You can probably tell his right eye or the left side on your screen. The eyelid here is a bit droopy. If you imagine lifting that eyelid, this eye doesn't seem well centered. This one's looking right at you, but this one's kind of drifting off to the side. So this is kind of classic for a condition you wouldn't want to miss. Again, a picture of it here, kind of this down and out configuration to the eye. The pupil might be dilated, the eyelid might be droopy. This is a third nerve palsy. So what's important about a third nerve palsy? Why might you care? Down and out, that's kind of the key word there. So with a third nerve palsy, you have a unilateral ptosis. It's typically not both sides. And then when you lift that eyelid, the eye is pointed down and it's pointed out. Patients will oftentimes complain of double vision. And then, of course, the droopy eyelid. Usually there's no pain or discomfort, though occasionally you can see that. And then when you actually look at that eye, when they try to read out of that eye, they see fairly well. The third nerve doesn't innervate, it's not the optic nerve. It doesn't carry vision with it. So when you lift that eyelid, they should have, their baseline vision. It shouldn't be significantly blurry. On the exam, if you try to have them look around, that eye is not going to move very well. It probably will just move temporally or laterally. That's because the lateral rectus moves the eye out that way, and that's controlled by a different nerve, the sixth cranial nerve. The pupil might be dilated, and that's because some of the parasympathetics run along the third cranial nerve, and those can become affected. You want to assess the other cranial nerves. If you have one cranial nerve that seems like it's being affected, what exactly is going on here? You want to look and see if there's anything else being affected. Okay, so what you see this patient in your clinic, how would you manage it? It's really important in these patients that you rule out an aneurysm, particularly in the posterior communicating artery. An aneurysm that's impinging on the third nerve and causing a third nerve palsy is at risk of rupture and cerebral hemorrhage, and certainly morbidity and even mortality. So it's a relative urgent emergency that you want to rule this out. Some specialists kind of go between an MRA or a CTA. A CTA really for most patients is just fine. It's quicker, you're going to be able to get it easier. You want to let your radiologist know what the complaint is, what they ought to be looking for, and a PCA aneurysm or a PCOM aneurysm is really the big thing. There are other causes of third nerve palsies that are much less emergent and certainly make up a wide variety of the third nerve palsies that we see, but you don't need to rule these out right away. An ophthalmologist can certainly look at these. You definitely want to, though, make sure you get a CTA. So microvascular ischemic, we see these in our vascular paths that can happen. Things like tumors, and then a condition called myasthenia gravis that can affect your eye muscles, your eyelids, and also your breathing as well. That can cause a similar type of presentation. So the PCOM basically runs next to the third cranial nerve, and if you get an aneurysm in it, over time it can impinge upon it. This is an angiogram showing an aneurysm there. And really the treatment for this, interventional radiology, our colleagues there will oftentimes embolize this aneurysm before it ruptures or bleeds and causes big problems. All right, so moving on now, we'll talk a little bit about retinal detachment. So this is a picture of the back of the eye. You can tell there's something going on here. The retina is the back of the eye. If you think of the eye kind of like a camera, you have the lens in the front, then you have the film in the back that captures light, back when we didn't all use digital cameras and phones. But the film in the back is the area of the eye of the camera that catches the light. That's what the retina does in the eye. So the light goes through our lens, and then it gets focused in the back of the eye. When there's a retinal detachment, the tissue there, the retina, is actually becoming lifted off of the eye, lifted away from the blood vessels that provide it nutrients, and the retina then can become ischemic and not work, and you can lose vision that way. So this is what a patient with retinal detachment might describe: a curtain coming across the eye or a veil. Notably, this doesn't move around. It's just there, and it stays there, and it can come from really any direction. Sometimes beforehand, they'll complain of floaters, a cobweb across your vision before this veil sets in. It usually will start peripherally, and then it can advance. The further progressed it becomes, the more into the center part of the vision it gets. Risk factors for retinal detachments: any history of trauma to the eye, and then we know that our nearsighted patients, if you're a -3, -4, -5, very nearsighted, you're at a risk of a retinal detachment more so than a patient that does not have that. That just has to do with the size of the eye. Nearsighted patients have larger eyes, and the retina tissue, we kind of all get the same amount of retina. That retina ends up getting stretched in these nearsighted eyes, and that stretching of the retina can predispose it to tearing and then detaching. So just a picture of the eye, the retina again in the back there. So how does a retinal detachment actually occur? So the gel inside of the eye, the back of the eye here, it can tug as it shifts around. It can tug on the retina, and it usually starts with a little tear or a hole. From there, fluid kind of makes its way through that hole and lifts up the retina and detaches it. So if you can catch a patient with just a tear in the retina, they don't have a detachment, then a very simple and effective procedure can be done in the clinic, just a laser that kind of spot welds the retina into place and prevents the detachment from happening and vision loss. Once you get to a retinal detachment, the only fix for that is really surgery in the vast majority of cases. An eye surgery where we remove the gel in the back of the eye and then we actually have to tack the retina down and kind of hope for the best. This is another picture of a retinal detachment. So the detachment is up here and it's starting to extend into the macula. Remember the macular degeneration was right here. Here's the optic nerve. When the detachment, if it ever were to get into the macula usually never behaves quite the same way once you tack that back down. It's very sensitive. So you want to, the central vision is really our most important vision, what we rely on when we're looking at things, looking at cars on the road, reading. We really want to preserve that central vision, and we want to make sure that the detachment, if you have a patient that you're concerned about a detachment, we really want to make sure that it doesn't get into the macula before it's treated, because once it gets there, the prognosis is much worse. All right, so any patient with new flashes or floaters, those can be signs of something going on in the retina, should have a dilated exam within 24 hours. So not the chronic floaters that many of us have. If a patient comes to you and they complain of dozens of new black spots in their vision or a cobweb in their vision, they should be seen within 24 hours, a dilated exam to see what's going on back there. Now, if the patient, on the other hand, complains of a curtain or a veil, so they've lost some vision, they can't see through that, they probably have already developed a retinal detachment, and they really should be seen that day. Or if it's after hours, the Callahan ER, 24 hours a day, they can take a look and we can take it from there. So you don't want to sit on something like that. We always tell our patients if they're having these signs and symptoms, don't wait, even if it's a holiday, just come in, let us take a look. If you're concerned about a detachment, just like with a globe injury, just to be safe, make the patient NPO. That can save everyone a bunch of time and get the treatment to them more quickly if they end up needing surgery. All right, just a little bit more here. So giant cell arteritis. This is one of those conditions that ophthalmologists and primary care physicians and rheumatologists and many people, many providers across all different specialties will deal with from time to time. So if you're suspicious for giant cell arteritis and the patient is complaining for vision loss, what do you do in this context? So GCA, obviously, it's a medium and large vessel vasculitis. It can affect the scalp, the temple, it can affect your arms, even your coronary arteries, or your large vessels, the aorta, and definitely the eyes, in particular the central retinal artery that feeds all of the blood that perfuses the eye. Risk factors for GCA, Caucasians are a little bit more high risk. It's relatively rare to see African Americans with GCA. Females are twice as likely compared to males to develop GCA. And then age, usually above 50 and primarily above 60 is when you start to see GCA. If you see a young patient, 30 years old with a headache and vision loss, it's probably not GCA, and you probably don't want to go down that path where you check them and put them on steroids for a long time without having them at least see an eye doctor first. So many of the symptoms of GCA, it's a tough condition to diagnose because a lot of these symptoms are non-specific, things like headaches. Jaw claudication is probably the most sensitive complaint. And it's really with chewing that they might notice that chewing food, and that's because there's some ischemia in the jaw when they're doing that activity that they notice the jaw claudication and jaw pain. Scalp tenderness or tenderness along the temporal artery, and then in terms of vision symptoms, amaurosis, kind of a curtain coming across their vision, flickering vision, or if it's very advanced and causing big problems, just total vision loss in that eye. And then constitutional symptoms, things like fevers, chills. Obviously, you can see those in many different things. So you really have to have have it on your mind to be looking out for it, to ask the right questions, to be able to diagnose it. So the inflamed temporal artery, sometimes you can palpate it. It might feel like kind of a cord-like type of thing, and painful. This is an example of GCA affecting the eye. So it's actually affected the central retinal artery that comes out from the middle of the eye. And it's caused loss of perfusion to the arteries in the eye. So this is an artery, a small capillary that's now showing some box scarring, so the blood is not perfusing through there like it normally would. These other vessels that you see that are still full, those are the veins, so the venous return is fine. It's just the arteries that are affected. And when the eye loses its perfusion, the retina very quickly begins to swell, you get whitening, and then this cherry red spot is kind of the classic thing for a central retinal artery occlusion. Because of the photoreceptors are very dense right here in the middle, that kind of gives off the sense that it's red there, even though everything else is kind of swollen and whitened. Giant cell arteritis, again, the vasculitis, it's a granulomatous type of inflammation. So really the definitive diagnosis is made with a biopsy of the temporal artery. You look at it under the slide, you see this type of inflammation. How would you manage a patient? So if you're clinically suspicious, you definitely would want to check a SED rate and a CRP. Do keep in mind that many of your patients, especially elderly patients, probably have reasons for an elevated SED rate or a CRP. And so if that's all you're going on and you're not that suspicious, maybe it's better not to check it. If you really don't think they're likely to have GCA, it's kind of that positive predictive value, negative predictive value, pretest probability type of thing. If you're just checking it just because they have a headache and they don't have any other symptoms, you might end up kind of going down a path that won't be very much fun for the patient or for you. But if they do have vision loss, they've got jaw claudication, the temporally, that's where the tenderness is, definitely keep a suspicion for it, especially in an older patient. So if the SED rate of the CRP is high, you want to start oral steroids. Sometimes you even consider IV steroids. Typically the dose we recommend is somewhere around 1 milligram per kilogram, so it ends up being somewhere around 40 to 100. That's daily. If they have significant vision loss, so hand motion vision or count fingers vision, you probably would want to consider just admitting them and then putting them on IV steroids, IV solumedrol in that case. The treatment goal for steroids in vision loss is really not to restore vision in the affected eye. That eye has lost its blood supply, it's not doing very well. It's really to protect the fellow eye, which is probably their only seeing eye at that point. Getting them on steroids from our standpoint to protect the fellow eye, to at least keep them seeing in one eye, and prevent them from becoming bilaterally blind. So you do not have to wait for the temporal artery biopsy to treat. You have up to a week after starting steroids where the temporal artery biopsy will still be a very sensitive test, and it should still show kind of that granulomatous inflammation. So definitely don't wait on that if you think the patient has GCA. All right. So in summary, acute eye diseases for non-eye doctors, they can be challenging to diagnose. But a simple and more focused exam, just kind of going through your list of progressions, what's their vision, what's their eye pressure, what's their pupil doing, and what does the eye actually look like? It should help you kind of triage and stratify, is this something that's really an emergency? Is this something I'm concerned about? Is this something where they're actually doing quite well? It's not a big deal, let's have you see someone within a week or two. A simple focused exam really should help you make that decision. Just try and be systematic about it. If the diagnosis is uncertain, you're uncomfortable, the patient's uncomfortable, don't hesitate to get the patient to the eye doctor. Oftentimes these eye diseases, if they're really something bad, the sooner you diagnose it and start treating it, the better it's going to be. And if it's after hours, again, we certainly are available. So again, every type of eye specialist, anytime, we're happy to see you. We also have several convenient locations across kind of the Birmingham metro area, even in Tuscaloosa and Gadsden. So if any of these are more convenient for your patient, don't hesitate to send them our way. I personally see patients downtown at Callahan, at Vestavia, off Montgomery Highway, in Pell City, where I was earlier today, and we'll be headed back after this, and then also at our new clinic in Gardendale. So thank you very much for your attention. I appreciate you coming here and letting me talk for a while. I'm certainly happy if you have a patient with a problem in your office. I'm happy to talk with you by phone and consult with you. I do quite a bit of that for both eye doctors and primary doctors. Happy to speak with you. That's my cell phone number there. And if you have any questions by email, don't hesitate to let me know as well. So thank you very much.